GLP-1 drugs are usually described as weight loss injections that suppress appetite. That description is not completely wrong, but it is too small. The more accurate story begins with a gut hormone. It moves through glucose regulation, stomach emptying, satiety signaling, brainstem pathways, hypothalamic appetite circuits, and then, finally, into the human trial data. So the question is not simply, do these drugs make people eat less? The better question is this: are semaglutide, tirzepatide, and related therapies best understood as gut-brain metabolic medicines? And does the evidence actually support the claims now being made about them? This is general education, not personal medical advice. This episode will not provide dosing, sourcing, switching, stopping, or treatment instructions. It will do one thing: follow the mechanism, then test it against the evidence. Before looking under the surface, one frame has to be removed. This is not a story about thinness as virtue. It is not a story about discipline, weakness, or finally giving people control. Weight is not a moral measure, and obesity medicine should not be reduced to appearance. The clinical question is more specific. In studied populations, do these medicines produce meaningful health changes? Do they reduce weight in a way that is durable while treatment continues? Do they improve outcomes beyond the scale in selected groups? And where do the claims run ahead of the evidence, especially around long-term maintenance, lean mass, real-world persistence, and vulnerable populations? Because reduced appetite can be therapeutic in some contexts and dangerous in others. Prescription medicines require individual clinical assessment, especially for people with medical complexity, psychiatric vulnerability, or current or past eating disorder risk. So the verdict has to be earned carefully. Mechanism first, evidence second, hype last. To understand why the appetite suppressant story is incomplete, start before the drug. GLP-1 is not originally a brand or a celebrity headline. It is a hormone signal produced in the gut, especially after nutrients arrive. Its full name is glucagon-like peptide 1, and it belongs to the incretin system, one of the ways the gut helps coordinate what the rest of the body does after eating. That matters because this is not a random pharmacological trick. The drugs are amplifying a pathway that already exists. Native GLP-1 helps coordinate digestion speed, glucose handling, satiety signaling, and communication between the gut and the nervous system. But mechanism is only the first step. A real pathway can make a therapy plausible. It cannot, by itself, prove long-term weight loss, cardiovascular benefit, safety, or durability. That is why the biology has to keep walking toward the trials. The pathway becomes clearer when you separate it into organs. At the pancreas, GLP-1 receptor activation supports glucose-dependent insulin secretion. That means insulin release is tied to glucose being elevated, rather than being a blunt signal in every circumstance. It can also reduce glucagon signaling in relevant glucose contexts, helping limit post-meal glucose excursions. At the stomach, GLP-1-based therapies can slow gastric emptying, especially early in treatment or around changes in exposure. That can contribute to fullness, but it also explains why gastrointestinal effects are so common. And then there is the nervous system. Signals from the gut interact with vagal pathways, the brainstem, and hypothalamic circuits that help regulate hunger, satiety, and energy intake. So the mechanism is not the stomach slows down, therefore weight falls. It is pancreas, stomach, gut-brain signaling, and central appetite regulation working through one connected metabolic network. When people say these drugs talk to the brain, the phrase needs care. They are not mind control. They do not erase the complexity of eating. Human food behavior involves biology, environment, stress, sleep, medication, culture, emotion, reward, disease, and access. But the brain is still part of the mechanism. Gut-derived signals and pharmacologic receptor activation interact with brainstem and hypothalamic circuits involved in hunger and satiety. In simplified terms, the therapy can change the strength of signals that tell the body food is needed, food is enough, or energy intake should continue. That is why willpower replacement is the wrong frame. These medicines are acting on biological signaling systems, not moral character. Still, the brain mechanism does not prove every cultural claim. It does not prove addiction treatment. It does not prove permanent metabolic reset. It does not prove safety for everyone. It only tells us why the next question is worth asking. What happened when this mechanism was tested in humans? Now, the mechanism changes from physiology to pharmacology. Native GLP-1 is short-lived. The body releases it as part of a normal post-meal signaling system, but the signal is rapidly broken down. Semaglutide is different. It is a long-acting GLP-1 receptor agonist, engineered to resist rapid breakdown and extend receptor activation over time. That is the bridge between hormone biology and drug effect. But this is also where a common mistake appears. Drug engineering can explain exposure. It can explain why a short gut hormone signal can become a longer pharmacologic signal. It cannot by itself prove how much weight changes, who benefits, who has side effects, or what happens after stopping. For that, the molecule has to leave the diagram and enter randomized human trials. Tirzepatide is often discussed as if it is simply a stronger version of an older GLP-1 drug. That framing is too crude. Tirzepatide activates both GIP and GLP-1 receptor pathways. In other words, it uses a dual incretin strategy, not just single GLP-1 receptor agonism. That difference matters because the larger average weight reductions seen in several obesity trials may relate to this combined receptor approach. But again, mechanism is not a ranking system. A different receptor strategy does not mean the drug is better for every person, every outcome, or every safety category. It does not turn trial averages into individual predictions. We have a real gut-brain hormone pathway. We have engineered drugs that extend or broaden incretin signaling. Now, the verdict depends on what actually happened in people. Now, the mechanism has to face the human data. The numbers matter, but only if the frame stays clear. Who was studied, what was compared, and how long treatment continued. In Step 1, adults with overweight or obesity, without diabetes, received semaglutide or placebo, alongside lifestyle intervention, for 68 weeks. The average body weight change was minus 14.9% with semaglutide, compared with minus 2.4% with placebo. About half of participants on semaglutide lost at least 15% of body weight. Step 5 then extended the semaglutide evidence over 2 years, showing roughly 15% mean weight loss at week 104, while treatment continued. For tirzepatide, SURMOUNT-1 showed larger average reductions over 72 weeks, about 15%, 19.5%, and 20.9% across active trial groups, compared with about 3% with placebo. So the tier is clear. Strong evidence for weight reduction in studied groups. Trial averages, not individual predictions. The next trial question is not just, can weight fall? It is, what happens when the drug is withdrawn? That question matters because it tests a very popular claim, the idea that these medicines permanently reset metabolism. SURMOUNT-4 used a withdrawal design. Participants first received tirzepatide during an open-label lead-in period. Then they were randomized either to continue treatment or switch to placebo. Continued treatment maintained and further increased weight reduction. Withdrawal led to substantial regain. Across the full 88 weeks, the reported mean weight reduction was about 25.3% in those continuing tirzepatide, compared with about 9.9% in those switched to placebo. That does not prove every person needs indefinite treatment. It does not give a viewer treatment instructions, but it does show why maintenance strategy, real-world persistence, tolerability, access and individual variability matter. In trial populations, stopping was commonly followed by regain. So short-course metabolic reset is not the evidence-based frame. Chronic biology behaves like chronic biology. Weight change is important, but in medicine, the scale is not the whole verdict. The stronger question is whether clinical outcomes change in defined groups. Select tested semaglutide in adults with overweight or obesity and established cardiovascular disease, but without diabetes. It reported a 20% relative reduction in major adverse cardiovascular events, cardiovascular death, non-fatal heart attack, or non-fatal stroke. That is outcome evidence in a specific higher-risk population. It is not just a body weight signal, and it is not a general population longevity claim. SURMOUNT-OSA tested Tirzepatide in adults with obesity and moderate to severe obstructive sleep apnea. It reduced sleep apnea severity, including apnea-hypopnea index, and improved sleep-related patient-reported outcomes. Other measures moved too, including body weight and some cardiometabolic markers. But not every moving marker carries the same clinical meaning. This is why the verdict cannot be cosmetic injection, but it also cannot be general longevity drug. Strong evidence does not mean unlimited evidence. This is where strong evidence has to be separated from cultural noise. Food noise and craving are real patient-reported descriptions for many people, and patient experience should not be dismissed. But food noise is not a single standardized clinical endpoint. It can be meaningful without proving every claim attached to it. The mechanism makes appetite and craving reports biologically plausible because food cues overlap with brain signaling systems. But plausibility is not the same as an approved addiction treatment. So addiction claims remain preliminary. Longevity claims remain unproven. Cosmetic use claims sit outside the strongest medical evidence. Safety also needs categories. Common effects are often gastrointestinal. Context-specific risks and warnings include gallbladder disease, pancreatitis warnings, dehydration-related kidney injury, hypoglycemia risk in relevant medication combinations, diabetic retinopathy contexts, pregnancy boundaries, procedure-related aspiration concerns, and contraindication categories. Product quality concerns are separate again. Compounded GLP-1 products should not be treated as equivalent to regulator-approved medicines. Warnings are not proof of harm in every person. They are reasons this belongs in individualized clinical assessment, not internet certainty. So, the calibrated verdict is this. GLP-1-based obesity drugs are not simply appetite suppressants. They are gut-brain metabolic therapies with strong evidence for weight reduction in studied adults and strong evidence for selected outcomes in defined clinical populations, including cardiovascular risk reduction with semaglutide and sleep apnea severity reduction with Tirzepatide. Established, meaningful weight reduction in trial populations. Strong, selected cardiovascular and obstructive sleep apnea outcomes. Preliminary, reward, craving, food noise, alcohol, and addiction-related claims. Unproven, general longevity, cosmetic transformation, and permanent metabolic reset. Unsupported, treating compounded products as equivalent to approved medicines. Still open, long-term mass exposure, maintenance strategy, lean mass, real-world persistence, individual variability, and eating disorder vulnerable populations. This is general education, not personal medical advice. Prescription medicines require individual clinical assessment, and personal decisions belong with a qualified clinician. The BS detector is simple. Ask what receptor is targeted, who was studied, what endpoint changed, what happened after stopping, what harms were tracked, and whether the product is approved, compounded, or investigational. Mechanism opens the door. Human evidence decides how far we can walk through it. If you enjoyed this video and perhaps gained some more informed knowledge on GLP-1 drugs, and if you would like to see more of these types of videos, please subscribe to my channel. It would be greatly appreciated. Until then, have a great day. I'm Mira, and I will see you next time.